Okay, video number 2 for the day. Pretty exciting stuff, right? In this video, I want to share really briefly this interesting root canal that I had an opportunity to do. Didn't anticipate it, but it turned out to be a pretty cool case, so let me share that with you. First of all, let me tell you, these are scratches or cracks on the X-ray sensor, so don't worry about these lines. I promise it's not the universe trying to speak to you. So this was an interesting case. This patient presented with some symptoms. She had kind of a constant ache or throb on tooth number 3. It was on the upper right. The X-ray, the PA that we have here didn't really clearly show anything. Now, after looking at that other X-ray, you can see a little bit of radiolucency here that could potentially draw your mind to think that something is happening in this tooth. But generally, it looks fairly unremarkable. Moderate size filling. In the absence of a really clear or deep dive investigation into this tooth, I wouldn't necessarily have called anything out here, absent the patient telling me she had some symptoms on this tooth. So we can see here there's a little bit of radiolucency, which the first thing I would assume, based on what I've seen in the past, is some sort of internal resorption. So we took a CBCT. Here's a bite wing, and again, there's just not anything really clear on this bite wing. Here's that same PA we were looking at before. Here's a 3D rendering. You can't really see much here. But the slices, these are 1 millimeter slices. You can see a definite radiolucency here in 3 planes. And it's pretty clear, a really obvious radiolucency. It's too round, though, for me to assume it's some sort of infection. So I have to assume that it's some sort of internal resorption. Now, maybe that's trauma related. Maybe it's not. I don't know. We may not ever know what's going on or what caused it. And in the absence of symptoms, this is something I would have just monitored. That's been my experience in my training in the past. When there aren't any symptoms associated with an internal resorptive lesion, as long as the tooth isn't compromised, it's something to monitor. Now, if that lesion were to increase in size or the tooth were to become symptomatic, then we could talk about treatment. But all that aside, the patient was symptomatic. So we did a little cold testing, and the tooth was necrotic. There was no vital tissue in the tooth. Here's another view of that tooth, a little bit wider field of view. You can see the area there. And she also had some thickening of the sinus wall here in her right maxillary sinus. Pretty clear that she has some issues there, in that tooth at least. So looking really closely, there's a lesion, obviously. So what we did is we went ahead and we prescribed a root canal. Now, I almost referred this out to a root canal specialist. Generally when there's a really complicated case, something that's outside of my comfort level, I'll refer it out. Most of the bread and butter root canal, the straightforward stuff, I will keep in the office and at least attempt to do myself. And I've had a pretty good success rate with completing root canals. So I'm not averse to attempting some of the quote-unquote more difficult root canals. So in this case, I told her, I'm not sure I'll be able to do this, but I'm happy to try. And the reason I had some questions is, if you can envision, once we remove that dent and triangle, being able to get through this hollow space into the open access of that mesial lingual canal. Where's the axial slice? Yeah. So mesial lingual canal. So the mesial buccal, the MB1, or the buccal side of that mesial canal, could easily get instrumented. But that mesial lingual, you'd fall into a big open area, and then you had to find the orifice on the other side of that resorptive lesion to get down through it to the rest of the apex. And I was pretty confident with my telescopes and being able to see with my loupes, I'd be able to get there. But I told the patient I just wasn't sure because, maybe there's a ledge in there. Maybe the anatomy inside would not allow you to get an instrument through there with any measure of success. So fortunately, what I ended up doing is I opened the tooth up. After getting down in there, I opened a standard access, and I wish I would have taken pictures now that you mention it or I mention it, to look down inside the tooth. And I took a burr. It was a longer diamond burr. And access straight down in there. So I had basically an open area that I could see, and I could look for that orifice. So again, the MB1 canal was easily accessible, but the MB2 canal was the concern. So here's the finished product, if you will. We have the distal buccal, the palatal, and we have an MB1 and an MB2. It's running basically parallel to it. But you can see how big that resorptive lesion was. I didn't widen this at all or extend it. I just disinfected it really well. It was rock solid dentin on the inside of the tooth. There was nothing soft except for the kind of granulation tissue that was inside there. So after getting down into that little opening, that chasm, that hollow spot, I was able to get down, get a working length, disinfect, and I used sodium hypochlorite and Q-mix, and then obturate. So I put in, Mastercone gutta percha with a bioceramic sealer, seared those off, and then I did the same thing, a little bioceramic sealer here, and packed some gutta percha in that spot, and then we put a big core buildup over the top and put a crown on it. So it was an interesting case. I wasn't necessarily expecting to be able to complete it. I thought perhaps I'd get in there and discover, hey, this is something that needs to go to an endodontist with a microscope. But fortunately, I was able to find the access, get into the orifice, and I was able to instrument that without too much difficulty. So, worst case scenario, if I wouldn't have been able to get in there, I would have been able to medicate the tooth and at least alleviate some of the patient's symptoms. Best case scenario would have been able to, finish it like we did. So I'm grateful that that case went smoothly. I think I picked that battle pretty well. Based on the CBCT, I was able to ascertain that there was an orifice after that little lesion down in the MB2 canal so that I could actually get in there. It was just a matter of finding it. And as many of you know, I use these 10x telescopes mounted on a headband. And so I'm able to see really, really well. And I think that was part of the key, is the magnification piece of the puzzle. So these are Surgitel 10X. I used to use 8X, but the 10s, mounted on a headband allow me this really steep angle of declination, which gives me, a lot of rest for my neck, and of course the magnification piece of the puzzle. So again, fun case. Really enjoyed the challenge of this case, and it was really unique to see this lesion, internal resorption lesion, in combination with a tooth that was symptomatic because it was necrotic, probably due to the filling or some sort of trauma. It's hard to know exactly, but the internal resorption lesion was like an incidental finding. It wasn't. I don't think it was causative. I think it was incidental. So thanks again for tuning in. If you have any comments, let me know. Thanks. Bye.